So with that note, I will usually start with my top 10 advances of interventional cardiology. So you know that until last year, I used to keep it only for a year before. So if I make 2021, and what happened in the last 5 months, I was a little far behind. So I changed now. So we're making it interventional cardiology 21-22. Means last June 1st to May 30th. Anything which has come in our field, because ACC particularly of the same year, which is one of the important meeting, many things come from there. So I changed this a little bit to our top advances. And I've said this tribute, where we are and able to do it, is by teaching. And of course, Andreas Grundzig is the father of angioplasty. DREAM was the catheter-based percutaneous treatment of vascular disease in alert and awake patient, which I added with utmost safety. Let's see what happened here. Okay, maybe I have to go this way. Okay, sorry. With utmost safety and appropriateness and ambulatory, of course, we know 60+% cases are done as an outpatient. So basically, idea is to select, which has changed our practice in last 1 year. So I want to start with the first one, is the cabbage turned down cases, which is the OPTIMUM registry. So patients who have complex disease, but turned by surgeons, by the heart team discussion, and this was the case, 750 cases in 22 centers, all very complex, very high syntax score. Reason for ineligibility is shown here. Many of them because of the poor target, bad LVs, lung disease, frailty, and look at the complexity of the angiographic characteristics on the left side, which we say these are the truly complex, and those are type of cases which we'll do few of them. And the left main being in 38% of cases, atherectomy in 1/3, and hemodynamic support in about 27%. But what did it show? Basically, that in these complex cases, very interesting, that many of these cases, we are able to decrease their syntax score. Means majority of the lesions were taken care. The syntax score of 0, only in 11%, but 1/3 of them became less than 8. Remember, the residual syntax score have correlated less than 8 is okay. So also, the key is that you can do them safely. And safely basically means that, yeah, you can do it. But what will be your predicted mortality in these patients? And you can see based on the various prediction of models that mortality was 5.6, in hospital was 3, and 6-month mortality is 12.3. You say, well, it seems to be high. But these are the cases which I can predict. If without intervention, their probably mortality would have been 25-30%. Also showed that your completeness of revascularization, that yes, you have better revascularization, your event rate goes down as well as health status improves. So anytime you even want to do complex cases, you need to target more complete revascularization. Second, relationship of hemoglobin A1C with cardiovascular outcomes post-PCI. So this is actually data from our large single center registry from Mount Sinai with Usman Babar, the lead author. Idea I suggested that let's see, we always talk about A1C, diabetic patient who have PCI. What does really matters in a large scale? So yes, some randomized trial where you are carefully followed is a different story, but what about in the general? So we have 14,000 patients, and we have A1C available for them before procedure. So this is the A1C, and you see the individual distribution of A1C 5.5, 5.5 to 6, 6 to 7, 7 to 8, more than 8. It's about half of the cases, the A1C was between 6 and 8. So these are the individual characteristics in each group. Clearly, once you go to a higher A1C, more than 8, more complex disease, multi-vessel disease, and the patients have other comorbid conditions. And interventional, of course, required because of complexity. More complex interventions were done for those patients. But more important, goal was different, not acute results. What happened to them for follow-up at 12 to 14 months? And you see here, we have death, MI, and target vessel revascularization. Look at the death. If your A1C is less than 5.5, it is 5.6% higher. Very low A1C associated with higher mortality. And if MI, higher with the high A1C. And of course, the TVR didn't matter. Slight trend, you can say, with the higher A1C, but really did not matter. Very interesting observation. I know some of the studies have shown that also. And we saw this kind of relationship with the A1C. So basically, it turns out to be that you have a trade-off. Too strict, patients die. We know that various of the diabetic trials have shown too much hypoglycemic episodes and so. So basically we concluded that patients undergoing PCI, pre-procedural A1C level display a U-shaped association with 1-year base pattern that reflects greater risk of death in presence of low A1C, 5.5, and high risk for MI values for more than 8. So there was a nice editorial with that. And more important is, I say, if somebody asks, what is the sweet spot with this? I think 6.5 to 7.5. Don't be too strict, and of course, not to be too high. That's what we learned from this data. Then the drug-coated balloon. I think for US interventionalists, it still remain a sore thumb in the sense that we don't have drug-coated balloon for coronary arteries. Lots and lots of data are coming. And basically, it works either in instant restenosis on the top or de novo. Basically, idea is the local drug delivery. No additional stent or metal is left in the vessel. And of course, it's a little different technique to use the drug-coated balloon compared to regular balloon or stent. You have to leave it for 60 to 90 seconds, but it has shown very effectiveness. And this I presented last year. The drug-coated balloon especially useful in the ISR, and the question is why? Because low DAPT dependence. So this multiple trials have shown actually mortality of various of the drug-coated balloon trials. Now, what we learned is that is actually going on at present. We have a lot of our European colleagues and from Asia that using drug-coated balloon in small arteries. Compare, question comes, in a small artery, you put a stent, already taken part of the lumen, metal. What if your drug-coated balloon will work? Now we have the 3-year data of the small basket, small 2, of the about 750 patients, and basically showed identical outcome. So drug-coated balloon is small artery in all the aspect, fares well with a drug-eluting stent. Even look at the stent thrombosis, although p-value was 0.18, but definitely lower with a drug-coated balloon compared to DES. Only thing is, if you put a stent in the drug-coated balloon situation, when you had for some dissection, the curve on the right side, that has a little higher event rate. So drug-coated balloon alone works very well. The individual, the data in terms of in diabetic and non-diabetic, it turns out to be the benefit is more in the diabetic on the lower, as you can see, with a drug-coated balloon compared to non-diabetic. So yes, non-diabetic doesn't make much difference, but diabetic, higher restenosis anyway, but significantly reduced TVR, no difference in MACE, but significant reduced TVR in a diabetic patient as shown here. So what about acute coronary syndrome? Benefit was both stable syndrome as well as acute coronary syndrome. So I would say a small 2 trials showed the drug-coated balloon is a good option in a small vessels. You do a good angiographic result. If you have no dissection, you leave it. And of course, you can always do a drug-eluting stent, but data are coming that probably is better, just do a drug-coated balloon. Then we have multiple imaging trials. Some of them may be confusing to you, which I'm going to present, but just to say enhance or improve our interventional results. So that's basically is. The decision is made by many times some of the devices, particularly FFR and IFR, and more importantly, additional multimodality imaging. And that is will be shown in the cases today, whether it's IVUS, OCT, or NIRS, and of course, even ambiguous lesion, you make a decision based on this imaging or with the FFR or IFR, which have been shown by the trial, has become kind of class 1 indication for us that in a borderline lesion of 40 to 70%, you do imaging or physiological imaging usually before proceed for intervention. And ultimate trial is the IVUS guided 3-year data, which we have now, that IVUS guided in the red compared to the blue angio guided, that overall significant improvement in outcome at 3 years. And there is another trial which showed the combination of both IVUS XPL and ultimate trial showing that benefit in mortality, not even just the TVR and TVL, but definitely benefit in mortality. And there's some data showed lower stent thrombosis by using imaging, particularly in complex cases. Now then, there was a trial called EyeSight, randomized trial comparing 3 aspects. Angiography guided, a small number, 50 in each group. IVUS guided or OCT guided. So is there a difference? It was a small trial, very intense, where criteria that what your protocol should be to get good results of the IVUS and OCT, and basically showed that overall much not different, but yes, by doing imaging, you do have a little higher fluoroscopy time and sometimes the contrast volume, but what did show that you have a better stent expansion compared to angiography alone. So although outcome at 2.5 here, a small number, there was no difference. So then the question came that do you do an intervention based on the FFR or based on the IVUS? And this is the FLAVOUR trial. A large number of patients, 1,700. So particularly intermediate lesion, 40 to 70%. You decide based on the IVUS. They have the criteria of the IVUS, which is that vessel size and so lumen less than 3 millimeter or between 3 to 4 with a plaque burden more than 70% or FFR less than 0.8, and then try to get optimal results. So basically, patient came for CATH possible intervention. You either an FFR group or IVUS group, and then proceed with intervention. What did happen? At 2 years, exactly identical outcomes. And the individual outcomes are shown here. Red is the FFR guided, and blue is the IVUS guided. There was no difference in angina class, as well as overall outcomes were different, whether you do FFR guided or IVUS guided intervention. There was another trial called Erosion 3, because many times we have patients who have MI, they basically got thrombolytic or just came late, and now we have only 60, 70%, but little ulcerated lesion. Should you stent them? Many people say, well, maybe the vessel is already open, infarction has occurred, maybe stenting not be beneficial, maybe we can follow them. There is a question about erosion, plaque rupture, and various things. So key is, decide based on the angio versus OCT guidance, and what it showed, that if you decide these patients, 226 patients, OCT guided on the left side, requiring stent, versus no stenting, you see that OCT guided stent was 44% versus 59% with the angiography guidance. And various OCT characteristics shown on the right side, and overall outcome were identical. So just to say that many of these cases you can defer stenting. And we know that in these cases, many times you develop slow flow and so using less stent probably is better in these cases without causing any bad outcome, which are shown here in this trial. Again, a small trial, but gives you idea that once you have lesion less than 70%, if you can do OCT and identify that this is there is not the erosion or so, they can be left alone. Then many times happens, patient is negative FFR, but they still develop event. So this is the combined FFR OCT trial. That can OCT predict on top of FFR in this FFR negative lesions? And what it basically showed that thin cap fibroatheroma. So if you have a thin cap fibroatheroma in the FFR negative, look at the event rate at 18 months, is 13% versus goes down to 3%. So your FFR negative sometimes have an event later on. Why? Because there was a thin cap and that ruptured and caused the event in future. There are 2 randomized trials which we need to wait to really put our imaging into actual class 1 indication. One is the defined GPS trial, which is IFR guided therapy, optimize your results. And secondly is the iLumen OCT versus angio. Will take a couple of years, but we'll have a final answer, kind of a level 1 indication, class 1 indication for these imaging in our interventional cardiology. Then the new CIN risk score after PCI and long-term MACE. So clearly, Dr. Mehran, authority, and she is the director of our interventional research at Mount Sinai and oversees our interventional database. And she actually came up to reanalyze the old risk, her Mehran's risk score, and come up with the latest what we have, because we know things, patient characteristic changes. This is the old Mehran's score, which taken together in terms of hypotension, balloon pump, CHF, age, anemia, diabetes, contrast volume, baseline creatinine, and used to come with a score. So that was one of the very highly cited score in our interventional cardiology, in a CIN, AKI score. So took this initiative to have a new modified, knowing that the definition of AKI are different with the ADQI or AKI, acute kidney injury network, or kidney disease improving global outcomes, and basically showed that let's look into that, are the predictors different at present in this contrast-associated kidney injury 48 hours, and then follow them for 1 year in terms of their outcome. And this is basically, again, large series from interventional database, again, 15,000 patients who have creatinine available in-house before procedure and discharge many times creatinine from outside, but we looked into cases which we have creatinine values, and overall, these are the study population that develop the set and then prospectively validate within the same group. Now look at the incidence of AKI. Very interesting. Over the years, our AKI incidence has gone down. Good news. Why? Because we are more conscious about it. Use a small dye, maybe some imaging. So clearly AKI incidence has gone down over the years, and more importantly, that the model which was created based on the pre-procedural variable and including post-procedure variable, and has a very good correlation in terms of the low risk, moderate, high risk, or very high risk of developing contrast-induced AKI. And this actually very nice illustration of coming up with a factor. So question comes, what does that all mean? So these are all various models and statistics showing, and more importantly, that patients who developed AKI, you can see their death rate is much higher versus those who did not develop kidney injury. So clearly, we need to do everything to prevent AKI. It's not only 30 days, even after 30 days as shown here. So there's a very nice editorial with the paper that we still have various parameters relevant in modern era, try to limit our dye and contrast induced. There's another data came that patients who develop from the ADAPT DES 2-year follow-up, those who develop contrast-induced AKI, kind of supplementary to the latest Maran's article, that those who develop contrast-induced nephropathy, they are normal creatinine even. So many of them, but you develop contrast-induced nephropathy, had a bad outcome at 2-year follow-up, individual one shown here. And this basically goes down to that if originally you have CKD, no CKD, then CKD with AKI, and the CKD without AKI, you see the gradient. So basically is that if you have even normal creatinine, you develop AKI, associated with the bad outcome at follow-up. But you have baseline high creatinine, develop AKI, trouble. 5% became 14% 3 times. And then more important, very nice editorial, that bump in creatinine post-PCI might bump off your patient. Nice editorial, just like we used to say for the peri-procedural MIs. And then go to the next one, and this is a lot of trials in this way, DAPT de-escalation. So we learned over, like I would say, until 5-6 years ago, all that focus was use a stronger antiplatelet therapy. Now in life, 5-6 years, we have many trials, and every year this is part of my top 10, that can we downgrade our de-escalation, use it maybe acutely when it's necessary. There was one trial in Talos AMI trial, ticagrelor versus clopidogrel in a stabilized patient with acute MI. That after, we know that after 30 days, we need a potent, but after 30 days, you don't need a potent inhibitor, because these patients do very good after good intervention. And so this was the trial that after 1 month, Talos AMI, everybody got aspirin ticagrelor, but after 1 month, they were randomized to aspirin plus clopidogrel versus aspirin plus ticagrelor. No loading was done for the clopidogrel, and this is up to, and followed up patients up to 12 months. So basically 1 month, a strong potent antiplatelet therapy, and see what? De-escalation. Event rate is almost half, and which were basically mediated by no difference in the MACE, although 1% lower, but biggest difference in the bleeding. So what we used to worry about in the past of the stent thrombosis and ischemic event does not happen nowadays. This has been stopped by trials after trials have shown that now. So go maybe in the acute phase, do the strong antiplatelet therapy. After that, your focus should be to decrease the bleeding. And that was, many papers have been published from our interventional database by Dr. Maran also, that it's the bleeding after the acute episode, which is a bad outcome in the PCI, kidney injury, another aspect, and so. So this actually goes to various trials which have put into this de-escalation, Talos AMI and the TICO, Twilight, Tropical, Popular Genetics, Host-Reduced Polytech, ACS, all basically having a common message that de-escalation is safe, no difference in ischemic output, endpoints, and it decreased the bleeding significantly. Then the whole question came, you are given your aspirin, clopidogrel, or whatever antiplatelet therapy for 6 to 12, 18 months. Now what? Usually what we do, we take away the clopidogrel, we continue aspirin. Is it better? Versus you change it to the clopidogrel. So this was like Capri trial. Capri, remember aspirin, clopidogrel on the various disease setup. So this is index PCI, then randomized after 6 to 18 months. You wanted to give DAPT, good. But now question is, you give aspirin alone or you give clopidogrel? Our usual practice is what? We give only aspirin. We take away the clopidogrel. So this is the primary outcome. Look at this one. On the right side, these patients, large number of patients, 4,500. And so 7.8% event in the aspirin and 5.6 in the clopidogrel. And see, basically mediated by 2 important things: ACS readmission and major bleeding. clearly, and then of course, clopidogrel was beneficial in decreasing stroke. So very interesting observation. So now, based on this trial, you can make it a point. If patient wants to continue clopidogrel rather than aspirin, we have the data to support for a long term. Then abbreviated DAPT trials in the same kind, which have been many other studies have shown. I'm going to talk about 2 of them, most important being the master DAPT, presented last year, published in NEJM. This is again, high bleeding risk patient, 30-day after PCI, and patient no event. You abbreviated DAPT, stop after 1 month, or you continue your 5 to 12 months as based on your recommendation. And these patients were high bleeding risk. They got a 1 stent only, ulti-master, and there was no restrictive based on the clinical presentation of PCI complexity. And basically, majority of those patients after acute time received clopidogrel after 1 month in the single DAPT group. And overall event rate, as you can see here, NACE, major adverse, as well as non-major bleeding, actually NACE and MACE, okay, but more important, that you decrease the bleeding. So again, the same message comes down that you decrease the major bleeding after, by abbreviating the DAPT. So they did a subgroup analysis, patient who have MI 1 year ago, still there was no difference. And lastly, in the complex cases also, they did not have any difference. They did not have acute MI and subsequent indications. So, but looks like that a patient with high bleeding risk is stopping antiplatelet therapy at 1 month is okay. Stop DAPT2 was a trial done to abbreviate your antiplatelet therapy after 1 month, but then ACS, especially in the acute coronary syndrome, wanted to see, can we stop it in 1 month? Remember, recommendation for DAPT at present is 1 year in acute coronary syndrome. Stable is 6 months. But question is, can we do it in acute coronary syndrome at 1 month? And these are the combination of both stop DAPT2 as well as some data from step DAPT2 and ACS. And overall, the overall endpoints are 3.2 versus 2.8, no difference. But more importantly here, you see the 1 month DAPT in blue in these patients, ACS patient, and 12 months in red. And overall event rates here, but one of the biggest issue is 1 month DAPT has a higher MI rate. Yes, bleeding is lower, that is true. But this is the first time de-escalation at 1 month compromised the patient's safety in terms of ischemic endpoint. There is another trial done 1 month of the DAPT, which taken all the patients together, no difference. But more important, even this trial, look at the ACS, 7.2 1 month DAPT versus 5.1 6 to 12 month DAPT. So message resonates that acute coronary syndrome should not stop in 1 month, preferably 6 months or so. And that actually goes to the guidelines, and part of the guideline have been incorporated 12i data that you can stop your aspirin after 1 to 3 months. Of course, bleeding risk patient, you can stop at less than 1 month and so. Then, of course, many patients, you may continue even beyond 12 months if appropriate. So next is the left main revascularization, the meta-analysis on EBC1, because remember, this is the 5-year data of the Excel, lot of controversy, overall endpoints were not different, but mortality was higher, 13% in the PCI group, 9.9 in the CABG group, although it was not a pre-specified, but clearly we knew that a lot of controversy about the mortality of the 5-year Excel trial. So then we have this meta-analysis of the 4 randomized trial of the Syntax, pre-combat novel Excel by Dr. Sabatin and Dr. Eugene Brownwald group of 4,400 patients and 5 to 10 year follow-up. And overall basically showed that these patients, the event rate of 5-year mortality or 10-year mortality is identical. There is 1% difference in 5 years. 0.2% mortality per year in the PCI group compared to CABG group. You take all the 4 trials. And that message is the same thing in 10 years. 1 year, 5 year become 1%, 10 year become 2%. And rest of the events as shown there, the stroke actually in early stage was lower with the PCI, but if you take all of them, no. Only difference is revascularization. You'll have a higher revascularization as shown here, and these are the individual endpoint. Spontaneous MI a little higher with the PCI versus CABG, and other endpoints were not different. So key is the patient with a more complex disease, high syntax score, definitely did better with the CABG. So that's what our goal is. That more complex disease with the left main, go for CABG. Less complex disease, go for PCI. So jury is still out there. I think still this will continue to hear more about. Then there was a trial that which technique you should use. DK Crush showed that 2 stents are better, but the European group took into that again to the challenge that what if we just do a stepwise provisional, means 1 stent, maybe second stent if needed, compared to dual stent strategy. And they used actually the technique which was not propagated by the DK Crush. So DK Crush was done in very small % of cases. It was all done with a Coulot. Coulot already had been shown by the DK Crush group that the DK Crush technique is better than Coulot, but that was the trial as such was. And 22% in the provisional stenting group got the stent, and overall outcome basically showed maybe slightly better outcome, but no difference in stepwise provisional versus systemic dual technique. So more of the technique. So just to come back, that rather than putting a 2 stents in the distal left main, this EBC one has raised the bar again, that maybe we should just do a 1 stent and optimize the results. It still remain. But I think this is a part of our heart team discussion, and when we'll get a class 1 indication, it still need to be seen. Then FFR trials. FFR has embedded in our interventional cardiology, in all our mind. We have to do everything with that based on the FFR. And we all know how good anything is, it comes back with full circle. There are a few trials in the past with plus minus, but majority have been plus. I say classical example is Digitalis, digoxin. Great drug at its time. Now it's like everybody thinks it's a poison, although I still use many times to control the rate, but nobody wants to use digoxin. So same way, so 2 major trials of the FFR. And the FAME3, that was FFR-guided PCI compared to CABG. These are the about 1,600 patients, FFR-guided, that you do PCI on lesion which are less than 0.8, leave others alone, or you do CABG based on the angiogram. This was a 3-vessel disease. Left main was excluded from this, and overall event rate and procedural characteristics are shown there. Done perfect job of what's supposed to be done. But look at the data. Non-inferiority versus superiority. To me, it's a superiority. I know the conclusion was that FFR-guided PCI, the FAME3 trial, FFR-guided revascularization was not non-inferior. It was basically inferior. 10.6 versus 6.9. Why? Look at the biggest issue remained, revascularization. 5.9. Many of those lesions which we deferred. Classical, we learned from the OCT FFR. May have thin cap fibroatheroma, for a few other lesions, they will give trouble. This is actually 1 year. Guess what the trials of the PCI versus CABG we have lost in 1 year? We have lost maybe in syntax, and that is only because they did a revascularization. But if you take away even revascularization, most of the trial of the current PCI and CABG were identical at 1 year and so. But clearly in 1 year to lose because of this strategy was not appropriate, in my opinion. So basically, just by FFR alone is not enough. Maybe we had to go a little further. We interventionalists do a little better job. Only one thing happened, the low syntax score we did good. But intermediate or high, of course, the CABG was better than PCI. So there was some, I would say, reassurance from the FAME3 trial that low syntax score, it said that yes, PCI is good, numerically better, but more important, event rates of the revascularization have gone down, and also, particularly, the quality of life parameter. The PCI did a better job in the short term. Of course, at 1 year, they were identical, and more return to work, younger patient. More patients return to work when they got the PCI compared to CABG, but that we would know from many other trials and so. The second trial of the FFR was in MI patients. You did a PCI of the STEMI, culprit vessel, but what about the non-culprit vessel? Do you do based on the angiogram or you do FFR, guided PCI for complete revascularization? And this is the trial that FFR-guided PCI, 66% got the stent, angio-guided almost everybody got the stent, and overall outcome angio-guided PCI was about no difference, but definitely not worse than FFR-guided. Individual endpoints are here. Overall, it did not make any difference, but still, there's about 1+%, 1.3% event rate higher in the FFR-guided, and that is basically revascularization. Look at that, 2% higher revascularization in FFR-guided versus angio-guided. So the whole idea of our FFR field has come to question by these 2 major negative trials. So people may want to make it in some positive way or so, but I think we need to understand a little more. Just FFR alone is not enough, and maybe an acute coronary syndrome is not enough. Maybe you need to think about something else in these cases, additional. And I would say the top 10 advance of interventional cardiology is the 2021 guideline for coronary artery revascularization, which Dr. Lawton and Jacqueline, who is one of the faculty here. Guess what? You know when was the last ACCHA guideline was? 2011. After 10 years, came with, very interesting, they actually have a lot of focus, not only just the patient or the lesion, but as the team, equity of care of the revascularization, ethnicity, race, then shared decision-making, and patient is at the center. Ultimately, decision is what patient decides. And you provide the whole aspect of the peri-procedural and post-care, not that just put a stent and you are done. No, you need to go beyond that. And they actually have all assessment of the heart team with the STS risk score, syntax score, and then the recommendation of the physiology, class 1 indication for the FFR, and imaging is 2A indication, pre, and they actually go through various aspects that which patient is good for revascularization compared to medical therapy. And I put it here clearly that patient with ischemic heart disease, if your indication to improve symptoms, patient with angina, revascularization is okay. Now, where you make FFR guided or so, that need to be seen. Second is those who have anatomic indication that we need to improve survival. From the survival point of view, if there is a left main disease, complex left main, suitable CABG, class 1 indication. But if it's not suitable for CABG, you don't let the patient die. You have a heart team discussion. Many of those patients will get like OPTIMUM trial, PCI, which will be okay. So whether it become class 1 and so. Then those who are no complexity, the PCI become 2A. Very important. Now, multivessel disease with PCI. This has been a little controversial. What they have put into here is LV dysfunction as the primary. So that is basically that if patient with anatomy not suitable, probably medical therapy is okay. But more importantly, if those who have cardiomyopathy, less than 50% ejection fraction and suitable for candidate, class 1 indication. But if in some cases you can have patients are not suitable, ejection fraction is more than 50%, then your PCI is 2B indication. So clearly here, the controversy was that in these patients with multivessel disease, CABG became 2B, no longer class 1 with this guideline, and that is one of the issue has been. A lot of people discuss that maybe correct or so, but these are based on the data that trials have been done. PCI has done a great job on many of these patients. Complex disease, they have with the diabetes, radial femoral, perform radial. The imaging is still 2A, and then calcific lesion, ISR, all the individual points, and then DAPT duration, same. They continued that you have 1 month for BMS, 6 months in stable patients for DES, and 1 year in the acute coronary syndrome, and so on. And dual antiplatelet therapy, cardiac rehabilitation, smoking cessation, and more importantly, also psychosocial risk factor, which you don't think much about. But key is that you need to have compliance of these patients at follow-up. So those are the top 10 advances of interventional cardiology for 2021 to 22. And I put this thing together, maybe because FFR-guided PCI versus CABG, FFR-guided PCI in MI, short DAPT in acute coronary syndrome is thumbs down. The PCI versus CABG and unprotected left main, PCI in CABG turned down, drug-coated balloon in small vessel, hemoglobin A1C and outcome, good data. Imaging-guided PCI, DAPT de-escalation, clopidogrel better than aspirin on long-term, and new CIN score, 2 thumbs up, and 3 thumbs up is short DAPT in high bleeding risk patient, and maybe sometime all cases. And more importantly, the 221 revascularization guideline really giving us some guidance, which we have been waiting for a long time to make us better interventionalist and so. So volume is going up. Interventional volume, people were concerned. What is happening? This is our data at Sinai. That of course 2022 was 2020 because of COVID was, but we definitely have a growth in both intervention, and more important actually is in the structural heart intervention. This is the latest data, the highest number in our New York with Mount Sinai with their respected 30% risk-adjusted mortality and significantly lower risk admission. So just to complete, the CCC live webcast has been a big hit. Over 2 million people with a CCC live webcast. Every month about 18,000, and both between live, our webcast and YouTube. And we'll be talking a little later. Dr. Keeney and team has developed this multiple cardiology apps, which are more than 60,000 download for everyone. And just want to thank all my cath lab attendings to be a part of this great organization which we have built at Mount Sinai. And thank you to be part of this one-day symposium today. Thank you very much. So with the usual, the tradition we keep, followed by this today's presentation, we can take off this now, slides. The Dr. Fuster, everyone knows Dr. Fuster has been the great mentor, personal advisor, all since I joined Mount Sinai in 1988. Achievements everyone knows about. Dr. Fuster is director of Mount Sinai Heart, physician-in-chief, and is the only one who has received the ultimate award from both ACCH and European Society of Cardiology. Every few weeks, we hear about another great, the medal and the award Dr. Fuster receives, but those are shown to bio. But more importantly is that Dr. Fuster keeps changing the message based on the time. As you remember that many, many years ago, it used to be platelet, but then revascularization, then diabetes, and now the imaging of the heart and the brain. So we really need to learn from Dr. Fuster how to keep changing with a changing time to give the great message to all of us. Dr. Fuster, thank you very much.